Hi everyone, thank you for joining us today. We're pleased to have Dr. Nick Sowers presenting today on traumatic cardiac arrest. Nick is an emergency medicine physician here at the QE2 site, as well as an associate professor for emergency medicine with Dalhousie University. He's also a member of our physician oversight team for our LifeFlight, EHS LifeFlight team, trauma team leader for us here at the HI site, as well as over the years, he's been involved in emergency medicine research and simulation training. So I will pass it over to Nick.
All right, good afternoon, everyone. Andrew, thank you very much for that introduction, and to Trauma Nova Scotia, thank you for having me. I think more accurate introduction is good afternoon. I'm Nick. I probably know many of you, and welcome. I don't really have any, I guess, specific disclosures or confessions or excuses. I am employed and teach and sometimes get paid for those things, as I'm sure you all do. I guess sort of the one request I would make is that given the nature of what we're talking about and I guess the degree to which this is being broadcast, you will notice that I'm not going to go into details about specific cases that I've seen, and I'm going to ask just in your questions or comments, I know Andrew's going to read those, maybe just if we can hold off on any details that may make cases identifiable. These are often fairly extreme cases, and I think probably easily identified. And so just in the interest of patient confidentiality, we'll try and keep things maybe a little vague, and I'll do the same. My objective for today is to try and uncomplicate traumatic cardiac arrest management, and to hopefully provide you guys with a cognitive framework that's more focused on the physiology of traumatic cardiac arrest, or the mechanisms by which traumatic injury patients sustain cardiac arrest. That's going to help you be more focused, more productive during a clinical situation that is absolutely incredibly stressful and often difficult to manage. Now, I know you guys were hoping to sit down and hear an hour of well analyzed, high quality research. But one of the things that I want to get right out of the very beginning is that the literature relating to traumatic cardiac arrest is pretty limited. I'm going to show you a few studies, but the number of large randomized control trials relating to traumatic cardiac arrest patients is pretty limited. So much so I would say is non-existent. And so the advice and the guidelines that do exist are often based on expert opinions and experience, and increasingly you will find with a focus on underlying physiologic principles, and that's kind of what I want to spend most of the time today talking about. The sort of themes, I guess, for today, or the intentions for today, are sort of these three, which is I want us to be realistic about the resuscitation of traumatic cardiac arrest. I want to outline a change in mental modeling or a change in the thought process of how we approach these patients. Then spend a little bit of time talking about some extreme interventions and specific patient populations, but more so with a focus on decision making rather than any one particular procedural element. I do want to start by painting a bit of a bleak picture. When you start researching a topic like this, one of the first things that comes up, or one of the most commonly cited publications that comes up, is one like this, which is it's about 10 years old now, but is a joint statement from the National Association of EMS Physicians and the American College of Surgeons. And the intention of this guideline was basically, if you have a patient with a traumatic cardiac arrest in the pre-hospital environment, how do we make decisions about terminating that resuscitation and not transferring that patient to an emergency department? And so when you start researching this topic and you realize that this is like one of the more frequently cited articles, it gives you a certain sense of the tone about what you're about to come across from a literature perspective. And that, in researching this topic, sort of going through the literature there, one of the things that I very quickly started to focus on, or wanted to convey to you guys, is that I think we need to be very realistic about the outcomes of these patients. If you are a major trauma patient who has sustained cardiac arrest acutely as a result of your traumatic injuries, the likelihood of that patient surviving is incredibly low. That's just the nature of the disease process, and one that I think if we're going to successfully resuscitate some of these patients, it's a statistic that we need to be aware of and to have some, I think, understanding and acceptance of. To give you a sense of what some of those numbers look like, there's a number of kind of cohort or population-based studies I want to show you quickly. This is from Sweden, a registry study of 1,700 patients with traumatic cardiac arrest, a survival rate of 3.7%. In France, 3,200 patients, survival rates even less at 1.6%. Closer to home, it's a registry study here in Canada, 2,300 patients, survival rate a little bit higher, 6.3%. However, the authors do very clearly want to make reference to the fact that about 80% of these survivors did have vital signs upon ED arrival, which is to say they either arrested in the trauma bay in the emergency department or arrested pre-hospital, but due to some resuscitative intervention like decompressing a tension pneumo in the field, had vital signs by the time they reached the emergency department. A study from the Netherlands, 1,900 patients, 3.9% survival rate, only half of whom had good neurologic outcomes as a result. A little bit higher survival rate from the London Air Ambulance Service of 7.5%. But again, keeping in mind, this is a service where there are physicians, emergency physicians, anesthetists as part of the on-scene resuscitation. This is the group I'm sure many of you have heard of that are doing roadside thoracotomies across London. So survival rates being a little bit higher for that group. And if you read through this literature, it's really easy to sort of kind of question it, to pick it apart a little bit, to challenge it. And you can ask questions like, well, how reliable is this? What's the denominator? Are we counting people who have died on scene and not transported? What about if you died pre-hospital, but you are transported and we don't ever get your pulse back in the emergency department? What are system differences that we need to think about? So does the service matter? Does it matter if you have a pre-hospital trauma physician on scene? Does it matter if it's ground versus air transport? And are there situational differences? So patients are resting pre-hospital, but they have their pulse back on arrival to the hospital. They arrive alive, but arrest in the emergency department, things like that. I don't really want to sort of go into the details and to spend too much time kind of belaboring these questions. But the reason I wanted to show you those studies up front was to give you a sense of what the survival rate actually looked like for these patients. And across the literature, it's probably somewhere in the neighborhood of 3 to 7%. And again, you compare that to medical cardiac arrest or out of hospital medical cardiac arrest, their survival rate is usually quoted about 8.6%. So maybe half of the survival rate of medical cardiac arrest. Now, the reason why I bring that up in the very beginning of the talk is not to purposely be depressing right off the gate, but if we are going to initiate what sometimes can be prolonged resuscitative efforts on patients who have an unlikely chance of surviving, we have to, I think, consider the potential risks and downsides of doing that. So say risks to healthcare providers from things like needle stick injuries, from infectious disease, from I think like the cumulative psychological injury of resuscitating patients like this that we maybe don't always put enough focus on, as well as risk to the public. So ambulances transporting patients across densely populated urban areas, the costs of resuscitation, the cost of resuscitation to that particular patient's resuscitation, but also to other emergency department or hospital patients with respect to resources and personnel who might be involved in a traumatic arrest resuscitation. And so given the fact that we have a patient population that has a very low likelihood of survival, and we're balancing that against some potential risks involved in initiating or continuing these resuscitative interventions, then I think it's incredibly important that when we're making the decisions about starting a resuscitation on a traumatic cardiac arrest, we do so in a way that's guided by some knowledge of factors that may increase or that may predict the likelihood of survival for that particular patient. This is a systematic review and meta-analysis that came out just about a year ago. A number of Canadian authors involved in this study, but again, looking at 53 studies, 37,000 traumatic cardiac arrest patients. And what they did was look for prognostic or identifiable factors, both pre-cardiac arrest and intracardiac arrest, that would predict survival, both or predict obtaining return of circulation, but also survival. And so things that they looked at are kind of things that you would maybe expect. So comparing blunt versus penetrating, did they get CPR or no CPR? How long were they pulseless? Things like that, to try and identify how we might predict a patient population that maybe is more likely to survive. Right? This is essentially the summary of their prognostic factors predicting survival to hospital discharge. And what you can see here, I guess there's two sort of takeaway. One is that most of the things that we look for, so mechanism of injury, time of downtime, penetrating blunt, did they get CPR, was it witnessed, yes or no? Most of that doesn't matter, right? What does seem to matter are two things. So is there an initial shockable rhythm? So is the patient in VTAC? That has an odds ratio of 7.3. So if you have a shockable rhythm, that is predictive of survival if you can manage that shockable rhythm. But the most significant, the most important thing that they found for predicting survival and predicting return of circulation was whether there was cardiac activity or cardiac motion on ultrasound with an odds ratio of 34. And so given the knowledge that an odds ratio of 34 associated with cardiac activity on an ultrasound, either on arrival or during the initial resuscitation of a traumatic cardiac arrest, given that odds ratio, and given the fact that none of the other things that we usually sort of look for are particularly helpful, I would suggest to you that if we're going to start anywhere in the resuscitation of these patients, it needs to be with an ultrasound looking at the patient's heart. That is such an important point that I do want to spend a few minutes going through some of these specific studies, looking at what they found and what their conclusions were. This is a study from San Francisco, Level 1 Trauma Center from a couple of years ago, 162 traumatic cardiac arrest patients. And what they did was they looked at ECG tracings and echo results either immediately upon arrival if the patient arrested in the field or immediately after the patient arrested if they did so in the emergency department. And what they showed was that if you were in PEA arrest without cardiac activity, your survival is 1.9%. But if you were in PEA arrest with organized cardiac activity on a bedside echo, your survival went up to 23.5%. Huge difference whether there's cardiac activity or not in your survival. There's another study, this one from Yale, Level 1 Trauma Center, smaller group, so only 28 patients. Again, looking at rhythm strips and again, asking that question early on in the resuscitation with an ultrasound to say, is there organized cardiac activity or not? If you had PEA without cardiac activity, no one survived, all right? And the authors would advocate that you can stop that resuscitation based on that piece of information alone. But if you had a PEA arrest with organized cardiac activity, they had an 11% survival out of the emergency department. Now, the authors don't comment on survival to discharge and whether they were neurologically intact, but as you all know, your discharge from hospital or your survival out of hospital starts with surviving to get into the hospital. The author's conclusion here being that the presence of cardiac activity represents a group where survival is possible and an invasive resuscitation may be reasonable. However, if the absence of cardiac activity portends death, then likely the resuscitation is not worth the risk to providers for that patient. There's another study, similar sort of thing, looking at 277 traumatic cardiac arrest patients in Arizona. The median CPR, pre-hospital CPR time for these patients was 20 minutes. They did an echo and an ECG, or echo and ECG rhythm strip on arrival. And again, dichotomizing patients into three groups. If you were in asystole, everyone died. If you were in PEA arrest without cardiac activity, everyone died. But if you were in PEA arrest with some organized cardiac activity on your ultrasound, their survival to hospital admission was 22%. This is a study from Kenji Naba's group in Los Angeles, 187 traumatic cardiac arrest patients. They're using FAST, kind of answering similar questions, but using FAST to try and make decisions around doing thoracotomies in the emergency department and predicting survival. They had 50% penetrating, 50% blunt, and 50% arrested pre-hospital. And essentially what they determined was that initial echo, as part of your, like, you immediately arrived and had an echo done or arrested in the emergency department, it was immediately done. But cardiac motion on echo at a sensitivity of 100% for either survival or organ donation following an ED thoracotomy. Right? Now, the reason why echo is important, or the reason why that question is important, is that the ultrasound or that echo that you're doing is trying to differentiate patients who have PEA arrest from those who have pseudo PEA arrest, right? The reason why that matters, or I guess the difference between the two, is that if you are in pulseless electrical activity without any cardiac motion or without any organized cardiac activity, that is a true form of cardiac arrest, of complete hemodynamic collapse. But a pseudo PEA is not. A pseudo PEA is an organized electrical rhythm on the monitor and organized cardiac activity on an echo, of which the cardiac output is below the threshold of generating a pulse. And so if we're trying to palpate pulses on these patients who look like they're in cardiac arrest, we won't feel pulses, right? And so if we don't feel a pulse, we start running that as a cardiac arrest. We start doing CPR, things like that we're used to doing. But a pseudo PEA is different from a true PEA, and that this is not a state of complete cardiac collapse, but is rather a state of severe hypotension below the threshold of generating a palpable pulse, which is to say, if you had an arterial line in these patients, you would still have a waveform, you would still have a map, it would just be really, really low, right? That is a group of patients who, doesn't matter what study you're looking at, has a higher likelihood of survival than those patients with no cardiac activity and those who are already in complete cardiac collapse. And so the take-home point so far from this is that asystole and PEA without cardiac activity are likely rhythms associated with death, and that if there are no other immediately reversible causes present, that providers or resuscitations may use that information to determine that termination or resuscitation may be totally appropriate. But if you have a patient in pseudo PEA, which is you don't feel any pulses, but there's organized electrical activity and there's organized cardiac activity on an echo, this likely represents the patient population that we are really looking for, that has the real potential for survival, and the patients that we absolutely should initiate what often can be complex resuscitations. Now, once we've sort of established who we're going to start running a resuscitation on, and we're using the objective measures, and echo being the one that I think we should be focusing on, once we've decided to start a resuscitation, I would encourage or advocate that we need to have a bit of a change in the mental modeling, the way we approach this, from the standard way we think about running a cardiac arrest, either anywhere in the hospital or in the emergency department. And that starts with a fundamental understanding that traumatic cardiac arrest is not the same as a medical cardiac arrest. When trauma patients decompensate into a critical low flow state, which is a pseudo PEA state, it is because mechanistically they're either profoundly hypovolemic from hemorrhage, they have an obstructive cardiogenic process such as a tension pneumothorax or cardiac tamponade, they are critically hypoxemic, or they have a catastrophic CNS lesion. And the successful resuscitation of these patients starts with a conceptual acknowledgement of what these underlying processes are that led to that patient's arrest. So much so that I think we can, more so I think than in medical cardiac arrest, but in trauma, we can make the argument that understanding the mechanism of why that patient arrested is directly related to the resuscitation steps that we should undertake. Now, I'll give you an example. If we're standing in the emergency department, all right, in our pod 2, we have 2 resuscitation beds in front of us, and we have 2 45-year-old males in those beds, and they both immediately arrest. And I suggest to you that we should give TNK. Well, if we understand that the mechanism of their cardiac arrest was because patient number 1 had a giant saddle pulmonary embolus, you might say, well, okay, that seems like a reasonable thing to consider doing, recognizing the underlying mechanism of their cardiac arrest. But if you understand that patient number 2 arrested because they're hemorrhaging in their abdomen from a giant splenic injury, well, you would look at me as if I was crazy. Right? It's understanding the mechanism of that patient's hemodynamic collapse that needs to dictate the interventions that we're providing. Now, when someone loses their pulse, right, when someone sustains a cardiac arrest, we often reflexively go back to ACLS. Someone says, well, can we start CPR? Can we get the crash cart? All of these things. Now, ACLS does not address the unique pathophysiology of traumatic cardiac arrest. Yes, I will fully acknowledge that buried in there somewhere in the H's and T's, there are a few things that are important. But overall, cumulatively, if you are going to run a traumatic cardiac arrest based on ACLS principles, ACLS misses the point. Right? what I would encourage you to do is that if a trauma patient arrests in front of you in your emergency department, stop doing CPR, put away the epinephrine, and throw this card away. Now, stop doing CPR is a fairly difficult concept to get around, right? There's just something about a patient's pulse disappearing that we immediately start doing CPR. It's just we're like trained, almost Pavlovian, that that's the right thing to do, right? But we need to de-emphasize the use of chest compressions in patients who have traumatic mechanisms of cardiac arrest. ILCOR made this statement a couple of years ago now, but fully acknowledging, I think, as the first major guideline to say that CPR should be de-emphasized in traumatic cardiac arrest, with an emphasis instead placed on correcting reversible causes of that patient's cardiac arrest. And I said in the very beginning, I want to talk about or want to focus more on physiology. And so if we're thinking about physiologic principles, well, what do chest compressions achieve? Well, if you do CPR, like really good CPR on a patient, that usually obtains cardiac output somewhere in the neighborhood of 25 to 30% of what their baseline cardiac output is. But that's in a medical cardiac arrest, assuming patients are largely euvolemic. But when the heart is empty because that patient has hemorrhaged, or when there's an obstructive component to the heart that's preventing cardiac output, such as a tension pneumo or a tamponade, the cardiac output from CPR is essentially minimal, and therefore should not be the focus of our resuscitation efforts. Now, are there robust clinical trials demonstrating this? No, absolutely not. And in fact, this is the kind of thing we have to talk about. This is a study from 2 years ago. It's an animal model study using 39 pigs as a model. And essentially what they did was they hemorrhaged them all to their MAP less than 20, and then they did CPR with a Lucas and put them into 5 groups. Group number 1 got chest compressions, group 2 got whole blood transfusions, 3 got normal saline, 4 was chest compressions and whole blood, and 5 was chest compressions and normal saline. And what you see on the diagram there on the lower right hand side is that the only models, the only patients that achieved return of spontaneous circulation were the ones that were transfused whole blood, right? If you did chest compressions on someone who had hemorrhaged out to a MAP less than 20, right, those chest compressions did absolutely nothing to improve their MAP and did nothing to improve the chance of returning to normal circulation, right? In fact, just perfusing or just giving them boluses of normal saline was more effective than giving them chest compression, right? Again, small study, animal model in a lab, but recognizing, I think, fundamentally the underlying physiology of why trauma patients sustain cardiac arrest, and that the use of chest compressions does not address that underlying cause or underlying mechanism of arrest. The other thing we need to keep in mind is to not underestimate how much CPR gets in the way, right? Many of these trauma patients need people on our resuscitation team up at the chest and up at the patient's head. And so if we're trying to get chest tubes in a patient, if we're trying to decompress the chest, if we're trying to get IOs in, for example, there's lots of things that we need to be doing that having someone there doing chest compressions hinders, gets in the way, and obstructs. Now, what about epinephrine if we're working our way through our ACLS pocket card because we haven't quite thrown it away yet? Is there a role for epinephrine in traumatic cardiac arrest? Well, I think you can honestly make an argument to say that there's not really a role for epinephrine in cardiac arrest in general. This is from Salim Razi in Texas, a nice summary of a number of the epinephrine for out-of-hospital cardiac arrest studies. And as many of you, I'm sure, are aware, what evidence supporting epinephrine use is that it increases the likelihood of ROSC, but doesn't actually show any neurologically intact survival difference. And so I think it's debatable whether there's overall benefit for epinephrine in medical cardiac arrest, but I think if we're physiologically thinking about what epinephrine does, it certainly doesn't make sense to use in traumatic cardiac arrest. Now, despite that, it's still advocated by ACLS for use in traumatic cardiac arrest. Is there any evidence to support that position? No, absolutely not. There isn't, not. In fact, there's increasing body of literature and evidence that would suggest the opposite. This is a post-hoc analysis of a fairly large cardiac arrest trial in ED patients in Japan. And essentially what they did was post-hoc went back and pulled out the traumatic mechanism cardiac arrest patients. They had 1,000 of them. and compared those who had epinephrine versus those who did not have epinephrine as part of their initial resuscitation. And they in fact show that there's actually a higher survival rate in the patients who did not get epi than those who did. Now, this is not demonstrating cause, this is not suggesting that the epinephrine did something harmful to these patients, but I think is a reasonable piece of evidence to suggest that we're certainly not withholding something valuable from our traumatic cardiac arrest patients if we withhold or if we don't focus on using epinephrine as ACLS would suggest, and instead focus more on reversible causes for their mechanism of underlying arrest. What does epinephrine do in cardiac arrest, just as we're talking about the underlying physiology? Well, as you guys know, it increases aortic diastolic pressure, which essentially is there to augment our coronary perfusion pressure. And so if the mechanism, or I would suggest if the mechanism of cardiac arrest was one that was hypoxemic in nature, whether that was traumatically driven, then I think using epinephrine as per ACLS probably makes sense, as long as you've now done something to oxygenate the patient. But if that mechanism of arrest for our trauma patient was hypovolemic from hemorrhage, whether it was obstructive cardiac shock in nature, then the use of epinephrine, I think, doesn't physiologically make sense. And there's really not any evidence to support using it. What if there's a shockable rhythm as our last step on our ACLS card? Well, this is probably the one thing that I think we absolutely can take away from ACLS and apply to a traumatic cardiac arrest population. If your patient has a shockable cardiac rhythm, your odds ratio for survival from that trend meta-analysis I showed you a few minutes ago was 7.3. So if your traumatic cardiac arrest patient loses their pulse and they're in VTAC, spark them up, all right? Absolutely, treat that as you normally would, but with the caveat, you should probably be thinking a little extra hard to say, was this actually a medical etiology of cardiac arrest that just happens to be masquerading as a trauma? So yes, that car went into the ditch, but did it go into the ditch because the driver had a run of VTAC and lost consciousness first? All right. You might say, well, I don't remember a traumatic cardiac arrest patient going into VT. That seems like it's pretty uncommon. This is from the TRAN meta-analysis, which say, yeah, it's not super common in that traumatic cardiac arrest is not in and of itself super common, but they found that roughly about 7% of traumatic cardiac arrest patients have a shockable rhythm. And so if you have a patient who has a shockable rhythm on your monitor, then we should treat that with electricity as per normal, as per ACLS. But that's probably the one component of an ACLS resuscitation that I think universally fits with traumatic cardiac arrest patients. Shock them when they need to be shocked. Now, the take-home points from this section, again, are to deprioritize chest compressions, recognizing that there's likely little benefit, little cardiac output from a hemorrhage patient or from one with an obstructive cardiac etiology, and that there's likely no role for epinephrine in traumatic cardiac arrest. Shockable rhythms absolutely should be treated as we normally would with electricity, as we normally would shock those patients in the emergency department. Now, so far, we've sort of picked apart ACLS, and apart from the use of the occasional jolt of electricity, we said, well, you can largely ignore most of what's on there. It does not address the unique physiology of traumatic cardiac arrest. And so if we're going to take away ACLS, can we default back? Can we think about, well, we still got ATLS to help us out in these situations, right? Well, we really don't, right? This is from the 10th edition of ATLS. This screenshot is the entirety of what ATLS has to say about traumatic cardiac arrest. And to be honest, they get more wrong than they get right? They'll make comments like, don't waste time doing echoes, give patients epinephrine, intubate them immediately. We've touched on a few of those. I don't want to address the rest of those things that I think ATLS gets wrong in the rest of the talk. And so if at this point we said, well, ACLS isn't really here to help us, and ATLS has not a whole lot of use for these patients when they arrest in the emergency department in front of us, well, what are we supposed to do? Do we hark back to the days of literally blowing smoke up our patients' asses? I don't think so, but we need some sort of cognitive model, I think, to help us get through these resuscitations. And I would suggest to you that a traumatic cardiac arrest resuscitation should probably look something like this, right? If we know that that patient has arrested pre-hospital, so we have some warning that this has occurred, we're going to start with what's called the 0-point survey. The trauma team leader, the emergency physician, who's ever in charge of that resuscitation is going to announce to the room a shift in focus. They're going to reiterate that this is a traumatic etiology of arrest, not a medical cardiac arrest, and that they are different. We're going to assign roles and priorities, and we're going to deprioritize the use of low yield or unhelpful interventions like CPR. Now, a 0-point survey is something that we kind of do already, or we maybe half do it, for most patients that are arriving to the emergency department. It's that discussion that you have before the patient arrives to try and get yourself organized. So it is an organized resuscitation before the primary survey that optimizes patient safety, optimizes provider performance for what is ultimately a complex team-based undertaking, right? So the sicker the patient, the more complex the resuscitation, the more valuable this likely is. And when you break it down, it sort of has components that look like this. So pre-resuscitation, there's a focus on self, on team, and on the environment. So if we're talking about resuscitating a traumatic cardiac arrest patient, tomorrow in the emergency department where you work, that may include things like if you need to pee, go pee, right? If you've got 5 minutes, that's something you probably should do, all right? Focus on allocating roles, all right? We've already talked about probably the most important initial step is to do an echo and figure out if there's cardiac activity or not. Well, know who's going to do that. Make sure that the ultrasound is in the room and it's plugged in and turned on. From an environmental perspective, the biggest thing that we're talking about for the last 2 years, obviously, are things like PPE, right? The idea behind the 0-point survey was that small steps in preparation, right, before a resuscitation, when summed together, can produce large advances in team performance and hopefully in patient outcomes. Now, let's say our patient arrives in the emergency department and are in traumatic cardiac arrest, or let's say they arrived with a vital signs or with a pulse and have arrested now in front of us. The initial steps that I think we need to do is we're going to stop CPR if someone has started it or if they arrived with CPR in progress. We're going to ensure that that patient has either IV or IO access. We're going to oxygenate the patient, and any number of ways we can do that. Nasal cannula, bag mask ventilator, supraglottic device. We're going to do a quick rhythm assessment, and that is literally, is the patient in a shockable rhythm right now? So if you're getting handover from EHS, from the paramedics, say, is the patient in VT? Were they ever in VT? Have a quick look at the transport monitor. That's as much as needs to go into that. And then we're going to immediately do an echo. Based upon the results of that echo, we can dichotomize these patients into 2 groups. There are those patients who are in cardiac standstill and those who have organized cardiac activity in the absence of a palpable pulse. So that pseudo PEA group that we talked about. If your patient is in cardiac standstill, all right, that is absolutely enough information for you to terminate resuscitation. All right. If you wish to continue, you can consider using bilateral finger thoracostomies to decrease both sides or decompress both sides of the chest. You can oxygenate or intubate that patient. You can bind the pelvis, transfuse blood if those things make sense based on what is likely the mechanism of injury. Right. But keep in mind that patient population that is in cardiac standstill is the patient population that very rarely ever survives. The patient group that we're looking for, the one that we're really going to focus our resuscitative efforts and our resources at, are those patients who are in pseudo PEA. So organized electrical activity, some organized cardiac contractility on echo, but no palpable pulse. These are patients that we need to be organized and we need to be quick. We are going to immediately decompress both sides of the chest, so bilateral finger thoracostomies. The person doing that has already been identified as part of our 0-point survey. We're going to oxygenate and or intubate, depending on what makes sense for that particular patient. We're going to bind the pelvis, all right, if this was a blunt mechanism of injury. We're going to start transfusing blood, and we're going to make decisions around invasive procedures like thoracotomies. You can tailor your resuscitation in some or all of these things based on what you think the likely mechanism of injury is. So if the patient has a penetrating chest injury, you don't need to worry about binding the pelvis, for example. All right, but this is the list of interventions that focuses at a recognition of what the underlying mechanism of cardiac arrest was. All right, and this is the list from which we're going to start. Now, is it really that important to intubate patients? All right, which is, as many of you, if you know me, you know that I am an airway management enthusiast, and there's nothing more that I like better than having to intubate someone really sick. And so it pains me a little bit sometimes to put this slide up. But let's call this an aside about not intubating from an airway enthusiast. All right? If you have a traumatic cardiac arrest patient and the mechanism of that cardiac arrest was pure hypoxemia, right? That patient is relatively rare outside of isolated head injuries, maxillofacial trauma, or neck injuries, right? And so what ends up happening is that although that patient population exists, right, they're relatively rare. And because they're rare, the more common population of non-head and neck trauma that led to hypoxemia, patient population group, we often, I think, put an undue or premature focus on intubation, right? And if you think back to your last time you took an ACLS course, that's right there at the beginning, it's A. And we often, I think, put an undue focus on that, not recognizing that the act of intubating someone, and I think more likely the positive pressure ventilation that follows that intubation, has the potential to harm the more common patient populations who are arresting because they hemorrhaged or because they have some obstructive cardiac shock etiology. And for some reason, we think about, or we often get this misconception of being an endotracheal tube being this like conduit to survival, and forget about the fact that positive pressure ventilation is a form of obstructive shock that we control. Intubate patients when they need to, but it is often not the priority, and it is a pro-con debate that you have to have very quickly with yourselves. Now, let's say we've worked through that process, right? We have oxygenated the patient, we have decompressed both sides of the chest, so we have eliminated a tension pneumothorax, we've bound the pelvis, we've transfused blood, we've ruled out cardiac tamponade, and our patient remains vital signs absent, especially if they have no cardiac or no organized cardiac activity in the echo. All right, this is absolutely the time when you can consider, I think, appropriately terminating the resuscitation of that patient. All right, it is very unlikely that that patient is going to survive in the absence of cardiac activity when you have done all of these things. Right, and this is the point where I think, if you wish, you can transition to following ACLS and starting CPR and epinephrine, if for whatever reason or whatever details of that case you think that that's appropriate for that patient. Or I think you can equally, or maybe more appropriately, terminate that resuscitation with the appropriate discussion and team brief with everyone in the room, either before stopping or immediately afterwards. Now, for those of you who give talks, who give presentations, many of you have been in this position where you're working on something and you're doing your lit review, and you kind of have a sense of what you want to say, and then you come across some publication that just came out that says exactly what you want to say, right? And gives you a nice graphic that you can put up. And this is exactly what's happened with traumatic cardiac arrest. A number of groups, a number of guidelines have sort of hinted at elements of this in recent years, but I think this is the most encompassing guideline or most encompassing document that addresses traumatic cardiac arrest from a physiologic or mechanistic understanding. This is a European Resuscitation Council guidelines from 2021 of cardiac arrest in special populations. And I included a couple of things here that they have advocated for that I think hopefully sound familiar from the last half an hour or so. So resuscitation of traumatic cardiac arrest should focus on immediate treatment of reversible causes, right? The response is time critical, and the success depends upon a well-established resuscitation, chain of survival, focusing initially on pre-hospital and specialized trauma care, right? Traumatic cardiac arrest happens because of hypovolemia, because of obstructive shock or neurogenic shock, and is different from the etiologies of cardiac arrest in medical patients. Use an ultrasound to identify the underlying cause of cardiac arrest and to help target your resuscitative interventions. Treat reversible causes, right? Chest compressions should not delay treatment of those reversible causes. And then in quotations, don't pump on an empty heart. I love everything about this because it is bang on accurate. There is a graphic or a poster that goes along with it from European Resuscitation Council that looks like this, that essentially sort of lays out a lot of what we've talked about. You'll notice on the left-hand side, they pulled out the couple of H's and T's from ACLS that actually make sense in trauma and tacked those on because we have to like give some nod to our background or our origins. But again, we're focusing on what are the reversible causes? Control external hemorrhage, volume resuscitate with blood products, secure an airway and oxygenate, decompress the patient's chest, bind the pelvis, and then give some consideration to some more advanced procedures, which we'll talk a little bit more about, right? If you obtain ROSC that's great. All right, move on to post-resuscitation care, damage control surgery, whatever it is that's appropriate for that patient. But if you have addressed all of the reversible causes outlined above and the ones that we have talked about and fail to obtain return of spontaneous circulation for these patients, that is absolutely appropriate to consider termination resuscitation, and I think including or needs to be included the appropriate team debrief. Now, I want to spend a little bit of time in the last sort of section of the talk talking about some extreme interventions and a few specific patient populations as it relates to decision-making in traumatic cardiac arrest. One of the most difficult decision points in this algorithm is around the decision to perform a thoracotomy in the emergency department. And so you might be asking yourself, or some may ask yourself, well, what's the downside? If we do a thoracotomy, it doesn't work, well, is there a downside to that? The patient was already dead. I would suggest this is sort of the downside that I keep in the back of my mind. My N of thoracotomies is 5. I have 1 neurointact survivor and 2 cases where residents got needle stick or scalpel injuries and ended up on post-exposure prophylaxis for a month, and the psychological stress that ultimately kind of comes from that. So it's not necessarily a benign procedure, as many of you are aware, for the patient or for the providers involved. Right? And so if we're trying to make decisions about doing something like a thoracotomy in a low volume center for a procedure like a thoracotomy, balancing the risks and benefits of that, well, what literature is there to help us from a decision-making perspective? This is from Western Trauma Association, looking at 6 years worth of data, 56 survivors of ED thoracotomy following traumatic cardiac arrest. And they went back and tried to identify what information was available about those patients during the initial elements of the resuscitation that might predict whether that thoracotomy was useful from a survival perspective or not. Their focus was on largely the duration of CPR. So they focus on pre-hospital CPR durations of 10 or 15 minutes, depending if it was a blunt or penetrating mechanism. And the author's conclusion being that the duration of pre-hospital CPR is likely a reliable measure of futility. However, we don't know what that time limit actually is. Right? I would make the argument, or I would make the suggestion, I guess, that I think a consideration for time does make some sense. However, I would wonder if we're using time as an absolute, as a surrogate marker for just the likelihood of there being cardiac activity on the echo or not. So does the duration of time just reflect the likelihood that this patient is going to be in PEA versus pseudo PEA? And the way I would think about it is that if I had a patient came in with a penetrating chest trauma at 12 minutes of downtime, but was in cardiac standstill and had no pericardial effusion, that's probably a patient I'm not going to open their chest. But if they were a penetrating injury and 22 minutes of CPR pre-hospital, but still had cardiac activity and had evidence of tamponade on a bedside ultrasound, that's probably someone I would open their chest. Right? I think that decision making needs to be on not just time, but what time likely represents, which is likely, I think, the potential for there being cardiac activity or not on your bedside ultrasound. This is that Kenji Nava study. I showed you this briefly, but again, 187 traumatic cardiac arrest patients in Los Angeles using FAST to determine whether the FAST predicted survivability from an ED thoracotomy. Their conclusion being that cardiac motion on a FAST prior to initiating an ED thoracotomy had a sensitivity of 100% for either predicting survival or for organ donation. And this is from the Eastern Society of Trauma, Surgery and Trauma. Again, a systematic review, 10,000 patients, and they sort of approached it slightly differently, which is a focus on specific PICO questions and scenarios with a stronger kind of concentration on individual patient factors, as opposed to just the focus on time or duration of CPR. Right? And they had a stronger focus on presenting signs of life. And this is sort of the list of questions that they came up with. The summary basically from them is that from a recommendation perspective, if you have a patient with a penetrating traumatic injury and signs of life, however they define those or however you define those at the bedside, that's a patient who probably should have a thoracotomy. If it's a blunt mechanism in the absence of signs of life, you probably shouldn't bother. And then everything else in between there is kind of a maybe, right? Depending on clinical circumstances. If you're looking for a guideline to tell you exactly what to do, isn't necessarily that helpful. This is sort of the way that I think about it if I'm the trauma team leader at the foot of the bedside, working in a low volume center. So I do think about very quickly low flow versus no flow times, how reliable was that information? As again, what is the mechanism of this patient's arrest, and what am I going to do with a thoracotomy? So is there a pericardial effusion or tamponade that I think we can evacuate or not? And are there signs of life? And I sort of spread patients out along a continuum, moving from I'm not going to do it to I am, using factors like, is there cardiac standstill versus pseudo PEA? Is there a tamponade or is there not? Are they in asystole or PEA rhythm? And then working down that, eventually thinking about things like blunt versus penetrating mechanism, and considering their downtime. So again, I think if we're going to make decisions around things like doing a thoracotomy in a low volume center, the more important decision-making factors to consider are, is this a patient in cardiac standstill or is there cardiac activity? Is there something that we think we can immediately do with that thoracotomy based on what we perceive to be the mechanism of arrest, i.e. is there a tamponade to evacuate or not? Difficult decisions, but I think we need to have some kind of foundation to how we are going to approach that decision making, recognizing that we do so in a very small window of time in a state of significant stress. Now, speaking of stress, all right, let's turn it up a notch. Right? What if our traumatic cardiac arrest patient was pregnant? All right, since we're talking a little bit about difficult decision making, which is I want to spend a couple of minutes just talking about the resuscitative hysterotomy. Right? Now, this is one of the most difficult decisions you will make in your career. And we make it harder by focusing on the wrong question, right? And the question that often gets asked is the fetus viable? And there's lots of guidelines and literature out there. So the SOGC, EAST, even the American Heart Association, they have given guidelines or recommendations around the viability of the fetus when performing what they have described as a perimortem C-section. Now, this is from Rosen's, which is like, it pains me to do this and throw emergency medicine under the bus. But this is from a previous edition of Rosen, which says, if there are no fetal heart tones, a cesarean section is not warranted. That is complete bullshit, right? This procedure has nothing to do with the fetus. This procedure is entirely about resuscitating the mother. And if the fetus survives or the fetus has a good outcome as a result of that procedure, it needs to be considered a bonus. The question we should be asking ourselves is the uterus big enough to compress the IVC and aorta? And that is why we need to focus, I think, about the language that we use. This is not a perimortem C-section. We're talking about doing a resuscitative hysterotomy. It is a resuscitative procedure that is intended to give the mother a chance, and as a result, potentially give the fetus a chance. I've stolen this image from Sarah Gray, who's an emerge doc and intensivist in Toronto, who gives an amazing talk on this. And so if it's a topic you're interested in, please Google that or find that resource. But essentially, the reason why we perform a resuscitative hysterotomy is because a gravid uterus, that weight sitting within the patient's abdomen and pelvis, by removing that, relieves aortic cable compression, it improves pulmonary mechanics, and it reduces the oxygen demand on the mother, right? And improves the likelihood that we may get a return of spontaneous circulation. Now, does it work? Well, obviously, this is not something that gets studied really well, and so what evidence exists is from a series of cases. All right, but what evidence, the numbers that are out there would suggest is that there's likely a survival benefit to the mother of around 30%, fetal survival associated with those procedures around 50%. And then Rose, who wrote a review of this for the American Journal of Obstetrics and Gynecology, made the quotation to say, well, there are no case reports where a resuscitative hysterotomy worsened maternal outcomes. Right, because she was already dead. That's me saying that now, right? So there's very little downside from a maternal perspective in performing this procedure if she is in cardiac arrest and the other initial elements to your resuscitation have not obtained a return of spontaneous circulation. The adage that is sort of attached to this procedure is the idea of start by 4 minutes and have the baby out by 5. This is based on a few case reports that are relatively old at this point. And so I think the idea or the notion of do this as quickly as possible, as soon as possible, it makes a lot of sense. But there are certainly case reports of maternal survival up to 15 to 20 minutes. So if you're 10 minutes into that cardiac arrest and you spent that initial minute doing things like decompressing the chest and binding the pelvis, and if those things haven't worked and you're 10 minutes in, that's still within the window of time that you absolutely should think about involving a resuscitative hysterotomy. Now, what if the cause or the mechanism of cardiac arrest was a catastrophic brain injury? I have to admit, I've been kind of a pessimist about these patients in the past. And this is sort of a group to me that I was like, if your catastrophic head injury is one that you sustain a cardiac arrest, I've always sort of been under the impression these are patients who aren't going to survive. I will say this is probably the group where the ACLS principles make the most sense. So is there a shockable rhythm, using epinephrine CPR, things like that, if this is an isolated neurosurgical injury, for example, right? Now, this paper came out just a couple of months ago, actually, from New York, a retrospective chart review of Level 1 Trauma Center looking at cardiac arrest or traumatic cardiac arrest in patients who had isolated severe traumatic brain injury. Small study, 42 patients, but found that they had 8 survivors, 7 of whom were neurologically intact. Now, this is what you will find for published literature on this particular patient population with this question in mind. But I think is certainly, a reasonable publication to make us maybe question, or maybe certainly make me question, a patient population that we might have considered to have, futile outcomes. The author's recommendation here, which I think makes a lot of sense, is that given the chance of survival with neurologic recovery, the traumatic cardiac arrest in patients with significant traumatic brain injuries or neurosurgical injuries, the fact that that's what their injury mechanism was, shouldn't stop that patient from getting the proper and appropriate resuscitation and ultimately appropriate neurosurgical care. Right? Maybe don't be as pessimistic as I was about these patients and run their arrests, same as you would for any other underlying mechanism of arrest. Now, I want to just very quickly touch on a topic that's one of those things that I often sort of forget about, but I think goes along with traumatic arrest in the context of neurosurgical injury, which is the concept of impact brain apnea. Right? This is a phenomenon characterized by essentially an abrupt traumatic injury to the head that is followed by this massive catecholamine surge. So 500 times roughly the usual sort of catecholamine surge of adrenaline and noradrenaline. And essentially what happens is these patients have massive episodes of hypertension followed immediately by cardiovascular collapse and apnea. These patients are often very resuscitatable though, if you can do so, if you can provide oxygenation and ventilation within the first kind of couple of minutes. It is thought that this process likely represents a significant number of the patients who we ultimately see in the ICU getting diagnosed as diffuse axonal injuries, for example, with anoxic elements of brain injury. And there are a few very interesting case reports of patients sustaining, blunt head injuries with complete cardiovascular collapse and apnea that just happen to do it right in front of a paramedic crew in an ambulance who are immediately able to start bag mask ventilating that patient, and those patients having really good outcomes. Right? Nothing really specific from an ED perspective because it's already happened and it's outside that, I think, that early window that's necessary for resuscitation by the time they reach the hospital, but I think a concept that we need to be aware of. The last thing I want to touch on, just because it kind of goes along with the catastrophic neurosurgical injuries, is the idea of traumatic cardiac arrest and organ donation. There are a number of studies or small publications out there similar to this one, which is a single center review, 340 traumatic cardiac arrest patients with a very low survival rate, only 5 survivors, all right? But 12 patients who survived to become organ donors. And all of those organ donors ultimately were patients that had non-survivable neurosurgical injuries. And the authors raised kind of a number of interesting questions that I don't know the answers to. But they're asking questions like, should we be resuscitating patients, only with the intention of organ donation? Should organ donation factor into our decision-making as to whether we terminate in the field versus transport to the hospital? Or is organ donation simply the benefit of sometimes complex resuscitations, that we start only to find out that the patient has some other non-survivable injury? Similar sort of, they were asking kind of similar questions. So traumatic cardiac arrest patients getting CPR pre-hospital, a fatality rate of 85%, which is actually, low compared to most studies that are out there. But again, looking at patients who had the potential to be resuscitated, ultimately for organ donation. These authors just making the comment to say that survival after traumatic cardiac arrest is certainly low, but recognizing that organ donation may be an important secondary outcome of these resuscitations. And finally, this one from Los Angeles, 263 traumatic cardiac arrest patients undergoing ED thoracotomy. 48 survived to get to the ICU, but 11 of those ultimately going on to organ donation. And the authors, I think, making the apt comment to say, well, the organs that were ultimately donated from these 11 individuals had the potential to alter survival for more recipients than the actual procedure of the thoracotomy did in the first place. Now, I don't think, and from personal perspective, I don't think we should be resuscitating traumatic cardiac arrest patients for the purpose of organ donation. But I do think that it's something we should keep in the back of our minds and be aware of, or I think just be kind of cognitively aware of, that organ donation might be an ultimate benefit for some of these complex resuscitations that we undertake in a patient population that has a very low likelihood of survival, as long as I think there was some legitimate reason to start that resuscitation for that specific patient in front of us. Take-home points I want to leave you with as we finish up today. Traumatic cardiac arrest, I think we need to be realistic, right? The survival rate for these patients is incredibly low. And I think we should go into these resuscitations with a really good understanding of who is likely to survive and what information we can use to make better decisions about how we start some of these complex and difficult resuscitations. We need a different mental model than ACLS or ATLS when we undertake these resuscitations. And I think the way to do that is a focus on reversible mechanisms of cardiac arrest, understanding the physiology of why this patient arrested, and using interventions that are specifically targeted at those underlying mechanisms for that particular patient in front of us. And then we spend a little bit of time talking about some extreme interventions, the ED thoracotomy, the resuscitative hysterotomy, not necessarily the procedures, but a little bit of thinking around some of the decision making that goes into doing some of these procedures on patients that are rare, but do on occasion present to the emergency department. And with that, I will take any questions if you want to put them in the chat. Andrea can read those out. If you want to reach out later on, there's my email, that's my Twitter handle. Please feel free to reach out at any time. Happy to discuss. And I thank you guys for your attention.
Thanks, Nick. Great presentation, lots of food for thought there, and appreciate your honesty throughout it as well. So if anybody has any questions, if they want to put them into the chat, there's several people online. It's hard for me just to find that particular person and unmute them. So if you just type your questions in the chat, we'll read them out to Nick and the group can hear the conversation. So there's a couple of thanks for a great presentation, Nick. There's one saying have an emergency physician part of the TTL team, which is our trauma team lead team, brings numerous cognitive offload and skills re-echo.
I think that's an important point. You know, when we do these sort of really difficult resuscitations, one of the things that we are increasingly trying to do in the emergency department is that if you have a second, attending physician there that you can cognitively offload to a little bit, that's really valuable. And we do that for lots of really, critically ill patients. But it's probably something that we could do a little bit more for trauma. So, if you are the TTL and you have one of these cases and you're just, you're distracted or you're trying to focus on a bunch of things, pull in the emergency charge physician just as that, sort of person to stand next to you just from a cognitive offload. Like, let's talk about this really quickly. Here's my understanding of what's going on. What do you think? Would you do anything different? That sort of thing. I think that's a very reasonable thing to do for any sick patient, but especially ones that are, particularly stressful or particularly time-centric like this. That makes a lot of sense. Big advocate.
Another question about, is there any data on the psychological trauma an inexperienced team faces seeing a pretty gruesome procedure like a thoracotomy?
It's a great question. I have no idea. If anybody knows that, like, send it to me. I'm interested to read that. I have no idea if there's any specific evidence or anything published about that specific question, but I think it's a very interesting one. And I think increasingly, as I get further out into my career, I think it is increasingly one that we have not put a lot of thought into historically, that I think we're going to see the cumulative effects of over time. So I think, there's not a lot you can do in the moment, but I think if you are, the decision maker, the one that's running a resuscitation, I think it is equally important the things you do in that resuscitation for the patient as it is the things you do for the other members of the care team afterwards, which is that any of these cases needs to have an appropriate debrief and the appropriate time allocated to it, that you can explain the decision making, that people can ask questions, that you can make sure that people are okay with it. Right. One of the things I do, so I've done a couple of times, not all that often, but a couple of times, is if you have a bunch of learners around, so residents or medical students, and you have a case that goes, is really upsetting, like a bad traumatic cardiac arrest that you stop, for example, as the attending or as a TTL, I will write my cell number or my email on the marker board in the room, and then make everyone in the room take a photo of it with their phone, so that everyone has it, and therefore no one knows who actually was writing it down. And then just say, listen, call me later, email me later if you have questions, if you're not okay, if you want to talk about this. I've done that a few times. I don't know if I've had anybody follow up with it, but I think we need to, especially as the attendings, as the TTLs, for example, I think we need to make sure that we're doing that sort of thing.
Yeah, I definitely think we've gotten better at it, the HI site, and I was just over the Dartmouth General site this morning as well, and it came up in conversation there that trying to kind of not formalize it, but to have a sheet available for the physician to kind of document the debrief, just, what do we think went well, what didn't go well, those kind of things, and have that conversation with people. But they are looking at a little bit of a form to go along with it that would be an NS Health form that would be available to everybody. A couple other questions here. Hold on, got a bunch of them in a row. Would you be able to hear a poorly perfusing heart via stethoscope in the field in lieu of an echo?
No, I largely think a stethoscope is a decoration that I use to convince the patients that I work there. No, I don't think so. It's a great question, and I don't have a good answer as to what do you do then when you don't have an echo in the field. The way I sort of approach that is, if I'm the one on the other end of the phone, I'm going to say, needle decompress both sides of the chest, and try and get aligned, and then try and give a fluid bolus, for example. But no, I don't think there's a lot of utility to a stethoscope, especially in an environment that's pre-hospital, that's loud, that's distracting, unfortunately.
And are there any differences, or are the stats of survival any different for PEDS patients?
I have no idea. I think they're roughly about the same. There's, as you can imagine, there's very little published out there about pediatric traumatic cardiac arrest. Sometimes, like some PEDS patients get kind of included in some of these bigger kind of cohort ones. I think they're roughly about the same as the adults, although the mechanisms sometimes are a little bit different, and like across a population, the mechanisms are a bit different, and the population, I think, fortunately, is much smaller. But I'll be honest, children terrify me, and I generally try and stay away from them as much as I can. So I didn't specifically look for that question, but it's a very good one.
There's a question about pre-hospital care. A question from pre-hospital care. When calling into the ER, what would be the most important points to hit on to best prepare the team for the incoming patient?
Yeah, it's a great question. If I'm the physician standing in the emergency department, I want to know what was the mechanism. Were there signs of life, apparent to the paramedics? Like, was the patient, did they have agonal respirations? Were they talking? That sort of thing. And when did that happen? And then I basically want to know, what have they done? Do they have an IV established? Have they needle decompressed the chest, if that made sense? That sort of thing. Basically, what I'd want to know, and then I guess, and then the advice is, this is one of those things where, like, there's very little you can do, like, other than needle decompressing the chest, for example, if that makes sense. There's not a lot that you can do, in the pre-hospital environment that's going to, I think, make a ton of difference. So it's one of those cases where, depending on what the transport time looks like, I would often favor like grab and run if you can get to the emergency department quickly, as opposed to, a longer resuscitation, on scene. So this is one of those ones of, like, if it's a penetrating chest, and they were, had signs of life and they rested in front of you, just needle both sides of the chest and get to the emergency department as quickly as you can. If it was blunt, bind the pelvis, get an IV if you can, you know, put some oxygen on the patient. But if you can get to the emergency department quickly, then I think that's what needs to happen. There's unfortunately not a lot that we can sometimes do for these patients in the pre-hospital environment. But what we can do, I think, is you know, start doing things that are not helpful, like, you know, spend extra time on scene by doing CPR, by giving epinephrine, things like that. I think it's probably more, especially within the city, or within a close transport time, you know, that it's probably more of the things that we shouldn't do that are going to delay maybe addressing some of those reversible things than what there is we can do.
Okay. If CPR is not interrupting other interventions in a traumatic pseudo-PEA, do you think CPR or no CPR would be preferable?
No, because even if it's not interrupting the actual like physical interventions you're trying to do, it's interrupting the cognitive ones, and it's a huge distracting thing in the room. Because if you've got somebody doing chest compressions that you think, as the one running resuscitation, you think those chest compressions are not useful, that still means that that's a really stressful resuscitation where you have the distracting factor of someone pumping on the chest and someone calling out every couple of minutes and lining people up for who's going to do CPR next. And you take some of the people on that resuscitation team that you need to do other things, and you exhaust them by having them do chest compressions. So no, I just, if it's a traumatic arrest, I'm going to address all of the reversible conditions and not do CPR.
Okay, any benefit to early art lines?
Great question. I don't know. I think it depends on what early means. I would say I don't need an art line, or I'm not interested in an art line, you know, until we got, you know, return of circulation. So if we're in that initial phase of, you know, decompressing the chest and getting large bore access and giving blood and binding the pelvis, no, I don't want an art line in there. You know, what we're looking for from improved hemodynamics is, you know, we're repeating the echo, we're feeling for pulses, that sort of thing. I want to address all those immediately reversible things that address reversible mechanistic things. And if we get that patient's pulse back, if, you know, if we're able to bind the pelvis and give blood, or we're able to decompress the tension pneumo, and that patient remains really unstable, but now has, say, a palpable pulse, and we've done all those more important things, then sure, that's a very appropriate time to put an art line in, as long as that's not getting in the way of something else. So I would like an art line, but I think the thought process behind the art line is that you've got to be very clear of like where in time you want it to go, and not have it take away or distract from, I think, the more important things that we're doing.
All right, thank you. That's all that I have in the question field at the moment.
Awesome. Thank you guys very much for attending. I really appreciate your attention. Hopefully this is the last time I ever do this online, and we'll do this in person next time. If you guys have any questions or anything you want to chat about later on, my email and Twitter are there on the screen. Please feel to reach out anytime. Happy to chat about this, or, you know, any other kind of resuscitation topics that you know, you got questions about. Happy to have a dialogue. Thank you guys very much. Appreciate your time.
Thanks for doing this, Nick. Thanks a lot.